There's a question I get from almost every woman who comes to see me after she's already been to 2 or 3 other providers. It's not, am I going to need surgery? It's, why has nobody been able to explain what's actually happening to me? I'm Dr. Tim Batita. I'm a dentist, a physician, and an oral and facial surgeon. Being trained as both a dentist and a physician, a significant part of my practice is treating TMJ disorders. I have treated thousands of TMJ patients, the large majority of them being women. Here's a pattern I noticed. The patients who had the most frustrating journeys getting here were almost never the ones with the most complex cases. They were the ones who had been handed the same partial explanation in a slightly different form by multiple people and never got the full picture. I'm going to walk you through why a specialist is needed, why women get caught in it more than anyone else, and what a complete explanation of your situation actually looks like, so that the next time you're sitting across from someone, you know whether you're getting the full picture or not. Point 1. The word TMJ is the beginning of the problem, not the explanation of it. You've been told you have TMJ. What that means practically is that you have a label, and the label hasn't translated into an answer that works. At some point, you've probably wondered whether TMJ is even a real diagnosis or just a placeholder for "we're not sure." The honest reason this doesn't get addressed clearly in most clinical settings is that TMJ has become a catch-all phrase for a wide range of jaw and facial pain, and not everyone using the term is making the same distinction. When a practitioner says TMJ, they might mean the joint itself is damaged or displaced, or they might mean the muscles around the joint are in spasm, or they might mean nerve involvement in the surrounding area. Those are 3 different problems. They respond to 3 different treatments, and they are regularly grouped under the same word and treated with the same protocol. Here's why that matters specifically for you. If you've been treated for a joint problem and your problem is actually in the surrounding muscle, the treatment was never going to work, no matter how well it was delivered. The research on this is actually pretty clear. Up to 85% of people presenting with what gets called TMJ pain have a problem in the muscles or soft tissue around the joint, not inside the joint itself. That's the majority. And the reason the numbers matter is that a muscle problem and a joint problem look similar from the outside, but require completely different approaches. The night guard, the muscle relaxers, the physical therapy referral, those are appropriate starting points for a muscular problem. They do very little for a structural problem inside the joint itself. And many times that distinction is either not clearly explained or it is not fully heard and understood when they hand you that night guard. Once you know those are 2 different things, you can start asking which one you actually have and whether the treatment you've been given was aimed at the right target. And that leads to the part that I think explains why women specifically end up in this loop longer than they should. Point 2, women are disproportionately affected by this condition and disproportionately undertreated. Those 2 things are connected. You may have noticed yourself, or you know other women with some version of this situation. Jaw pain, headaches that won't respond to anything, a bite that never feels right, tension that lives in the face and the neck. You've probably wondered why it seems to hit women so much harder, and whether that has anything to do with why it's so hard to get a satisfying answer. The demographic reality of TMJ disorders is not something most practitioners walk patients through. The majority of people with significant TMJ symptoms are women, often in their 20s through their 50s, often in high-stress roles, often with a history of being told their pain presentation is atypical or anxiety-driven. The clinical reality is that hormonal factors, joint laxity changes, the anatomical tendencies, and the way stress loads into the jaw and face are all genuinely different in women than in men. Those differences affect how the condition presents and how it progresses. They are not regularly accounted for in a standard TMJ workup. Here's what that means in practice. Women are disproportionately affected by jaw and facial pain. It's 9-to-1 women to men. The typical TMJ patient is a woman in their 20s to 50s. 90% of patients seeking treatment for TMJ-related disorders are women. Most treatment protocols weren't built with her specifically in mind. When I see a woman who has been dealing with this for years, I'm looking at how stress loads into the jaw differently in women, how hormones affect joint stability, and whether this is a muscular problem or a structural one. Those things matter for what I recommend. A generic facial pain workup doesn't account for any of them. Which brings me to the diagnostic piece that I find most patients have never been walked through, even after multiple consultations. If this is starting to make the picture clear for you, subscribe. I put out videos specifically for patients who are done getting incomplete answers. There's a related video linked in the description on how to tell the difference between a joint problem and a muscular problem before you ever see a specialist. That one's worth watching before your next appointment. Point 3. Here's how to tell whether your situation has been read correctly. The practical version of what you've been carrying is this. How do I know if what I have is the kind of thing that gets better or the kind of thing that's been getting worse while I've been waiting? And how do I know if any of the treatments I've already tried were even aimed at the right thing? There are specific patterns in how pain presents, when it's worse, when it travels, and how it responds to different interventions. That tells a trained clinician whether the primary problem is inside the joint, in the surrounding muscle, or neurological. Each of those has a different fingerprint. If no one has ever walked you through what your fingerprint looks like, the diagnostic picture is incomplete. Here are some of the questions to ask yourself. Is your pain worse in the morning when you wake up, or does it build throughout the day? Does the pain stay in one place, or does it travel to your temple, your ear, or your neck? Have you had a night guard? Did it help initially and then stop working, or did it never make a real difference? Do you hear clicking or popping? And is that the main problem, or is it pain that dominates the issue regardless of the sound? Has anyone taken a 3D CT scan of your joint? Have you ever had an MRI of the TMJs? Does your jaw have full range of motion, or is it limited? If you've answered those questions differently at different appointments and gotten the same treatment recommendation each and every time, the treatment was not being matched to your specific presentation. Morning pain that eases throughout the day points towards something different than pain that builds and doesn't move. Most patients are never told that distinction ever exists. The last thing I want to address is the one I find women specifically are least likely to push back on, even when they should. Point number 4. The referral you were never given is the one that would have changed everything. The number one most common practitioner who was sought after in order to treat jaw pain or TMJ disorders is the dentist. And that makes so much sense. TMJ disorders and jaw pain fall right into the scope of the dental field. Specifically, it falls to a specialist within dentistry. It takes a real passion and an extra level of study to fully understand the temporomandibular joint, the surrounding anatomical structures, the related disorders, and the full scope of treatments. A general dentist can offer a night guard, a physical therapist can address muscle involvement, and an ENT can rule out referred ear pain. What very few of them can do is treat the full spectrum, from the most conservative and medicinal treatments all the way through to the procedural and surgical options, and then actually choose the right point on the spectrum for your specific case. That full spectrum practitioner exists. Many patients are never referred to one because that specialist may not be in their area, so the referral doesn't happen. The patient continues in the loop with whoever they started with, trying variations of the same treatment. Here's the version of this I see most often. A patient has failed all kinds of conservative therapies. She has tried different medications to get rid of the pain. The pain becomes chronic and starts to drive her mad. For those that have dealt with chronic pain, you know it can change your mood, your personality, and if severe enough, it can start to drive you quite literally insane. Because of this, many patients have even been placed on psych medications. So this picture is a woman with chronic TMJ pain, and they were a perfect candidate for a simple procedural evaluation 2 years ago, but they are still adjusting her night guard, trying to find a solution. The patients who come to me after the longest journeys almost always described the same sequence. Each provider they saw was confident in what they were doing. Then eventually they said, "This is where my scope ends, and this is where you need to go next." By the time I'm in the room with them, the question is not just how do we treat this, it's how do we treat this accounting for everything that's already been tried, knowing the patient has had a long journey up to this point. If your provider has told you clearly what they can treat and what they can't, and has a plan for what happens if the first approach doesn't work, that's the right kind of doctor. Stay with that person. But if you're spinning your wheels or feeling dismissed, it's time to look elsewhere. And here's the concrete thing you can walk out of this video and do today. Point 5, what to actually do before your next appointment. The single variable most within your control right now is the quality of the conversation you walk into next. Not the diagnosis itself, not the treatment, but whether the person across from you is working from a complete picture or a partial one. You can change that by changing what you bring into the room. The history is the data. Your TMJ successes and failures matter, and you're the only one who has all of it. When you walk in with the history organized, you change what the practitioner can do with the time they have, and you can make it a lot easier and change the appointment from ending with a shrug and a script to a definitive diagnosis and a multifactorial treatment plan. Before your next appointment, write down these 3 things. When the pain started and what was happening in your life around that time: stress, bite changes, dental work, injury, etc. 2, what makes it better and what makes it worse: the time of day, specific foods, job movements, stress, etc. 3, every treatment you've tried, what it helped with, what it didn't touch, and for how long each effect lasted. Then remember to ask these 3 questions directly. Which specific structure do you believe is causing my pain? What does my imaging show about the structure specifically? And if this approach doesn't produce a clear improvement in 6 weeks, what is the next step? If the practitioner can answer those 3 questions clearly, that's useful information. If not, then it tells you where the edges of their scope are, and it tells you whether you need a referral to someone who works across the full spectrum. The women who've had the hardest time getting answers for this are not the ones with the most complicated cases. What is happening has a real explanation, a real diagnosis. You don't have to live with it forever. A complete explanation exists. A treatment plan that starts conservative and escalates correctly exists. And a practitioner who can walk you through the whole thing, not just the piece that fits their scope, exists. You're allowed to keep looking until you find that. The video that goes with this one is linked right here. It walks through exactly how 2 categories of jaw pain are different and what a proper workup for each one looks like. Watch that one next. I'm Dr. Tim Batista. Stay healthy, share your smile with others, and I'll see you in the next video.